I think one way it will look in the next few years, I don't think we're going to have a lot of dramatic changes in diagnostic testing. I mean, there's not echocardiography is always advancing to some degree. Right heart catheterization methods have been pretty standard for the past 25 years. Really, not a lot's changed. I think suspecting it'll be key, getting these tests, ruling out other causes, pinning down the cause of the PH, and if it's PAH, pinning down the cause furthermore, is it idiopathic, scleroderma, liver disease, HIV, these kinds of things, and then getting on therapy. I think one of the biggest changes will be patients will be on more therapies and maybe started early. We think about this sort of cancer analogy. In cancer patients, often there's aggressive induction therapy at first. You blast someone out of the water, you aggressive with therapy, and with PH, we haven't tended to do that. I've often thought it would make sense to put someone on intravenous prostacyclin right up front, like we used to have to do. Put them on Veletri right away, titrate it up, see how they do, get them on some oral therapy, and maybe wean that off in 6 months or a year. The study hasn't been done. It's hard to convince people to go on parenteral therapy when they're doing pretty well, when now we have some pretty darn good oral therapies. But again, the triple therapy approach I think is going to be a big one, and maybe even drugs with new mechanisms. Right now we're treating the endothelin receptor pathway, the PG, the PD5 inhibitor pathway, the phosphodiesterase inhibitor pathway, and the prostanoid pathway. But the inflammation analogy, the cancer analogy, patients with cancer have aerobic glycolysis. Why is that? Well, there's analogies in pH. The same thing might occur. Should we be using dichloroacetate or one of these drugs? Epigenetics are huge now. Things like histone modification, microRNAs, exploring these things, doing different kinds of omics, metabolomics, proteinomics, and deeper dives into phenotyping, I think will be really important in the future too.
Yeah, I mean, we're continuing to invest heavily in this area. There's a lot of interest in it, and a lot of, we've made a lot of progress, but we have a long way to go still. I agree. I think we'll see more and more people on combination therapies in the future. But we continue to look for, new targets, new opportunities. Sadly, there's nothing in the real near-term future, but hopefully over the next 4 or 5 years, we'll start to see some new opportunities and options coming forward. Similarly, on the diagnostic side, we continue to look for biomarkers, for things that we can use to, identify the disease earlier and track it. And there's a lot of efforts ongoing to identify things that may help in the diagnosis of the disease.
There's been interest in implantable monitors that can measure your PA pressure moment to moment. I personally am not sure we need that. I think we could do a pretty good job without that kind of thing. But I think, as Gary mentioned, we may not have a lot of changes in how we do echoes or right heart caths, and maybe we will. Maybe we'll get better non-invasive diagnostic testing for stroke volume, cardiac output, things like that with a finger probe. But again, I think the key thing is this diving in the phenotype. And right now, phenotypes are just, do you have PH? Is it idiopathic or scleroderma? Knowing much more about genes, I think will help us advance the field.